You know, I just love that picture. We call it the young otologist. You might ask, well, just what is an otologist? Well, I'm an otologist. I'm a physician that limits my practice to surgery and diseases of the ear. And I want to spend an hour on the ear with you, tell you a little bit about how the ear functions, what are some of the many things that can go wrong with it, what we can do about these things, and I'm also going to show you about 10 minutes of a videotaped operation. You know, but before I get started, there are two things that I'm often asked. I'll get talking about the ear and how we hear, and someone will always ask me, what about wax in the ear, and what about head noise, tinnitus, noise in the ear? Well, I'm going to say a few words about that a little later, but let me first show you a little bit about wax. You know, it's rarely necessary in my practice to wash wax out of the ear. Likewise, it's rarely necessary to chisel it out. In Taiwan, they have designed little instruments. I'll let you take a look at them up closer. These are actually bamboo ear wax cleaners. This is a picture that I took when I was visiting Calcutta about 8 years ago. And there are men sitting on the street down there who make their living out of cleaning wax out of people's ears. And they come, it's quite a ritual, and they do this and clean it out, and they put oil in the ear. You'll notice right over here there's a little satchel. Well, that not only holds the person's, the oil that he puts in the ear, but he has lots of spare ear wax there. In case he doesn't find any in the individual's ear, he can impress him with how much was cleaned out. Here's a diagram of the ear, and we're going to get back to this in a minute and talk about how the ear functions. But all I want to point out now is this ball of wax. Here's the outer ear and the ear canal. Now, wax normally forms only in the outer part of the ear canal, and it will indeed build up as a little ball of wax like that. But it normally melts and comes out of the ear during sleep. And all one has to do is to wipe out here to wipe off the wax. Wax is normal. Now, for those of you who are in the habit of always cleaning your ears with a wash rag or a Q-tip, this is what may happen. You may actually push the wax down against the eardrum. It was out here and you pushed it in. And that's about the only time that wax causes any real problem, when you've pushed it into the ear. So the old motto is, don't put anything in your ear smaller than your elbow. Well, I think at this point we ought to get on and talk a little bit about the mechanism of hearing and how the ear works. And we're going to come back to this slide 2 or 3 times during the presentation, but let me just orient you. Here's the outer ear, and the ear canal, and the eardrum. Now, this outer canal we call the external auditory meatus. It's about 1.5 inches long, and although it looks quite straight here, in fact, it's quite curved. And it leads down to the eardrum membrane. Now, as sound comes in the ear as vibrations in air, it causes the eardrum to vibrate. These vibrations are extremely minute, but they are transmitted then through 3 small ear bones: the malleus, or hammer, the incus, or anvil, and the stapes, or stirrup bone. And when this little stirrup bone vibrates, it stimulates fluid waves in the inner ear hearing canal, which we call the cochlea. So the eardrum and 3 little ear bones act like a transformer to transform vibrations in air occurring here into fluid waves in the inner ear. Now, these fluid waves in the inner ear travel through this coiled area we call the cochlea, and in so doing they stimulate the delicate little nerve endings. And you know there are over 24,000 little nerve endings that we call hair cells in this area here. And when they're stimulated, that generates an electrical impulse, and that electrical impulse is transmitted on the hearing nerve onto the brain, and when it arrives there, it's recognized as sound. Now, there's some other things in the ear. Some of you know this already. You've got your 3 balance canals. You've got what's called the facial nerve, which goes through the ear on a long course and supplies muscles of the face. And you've got what we call the internal auditory canal that contains the hearing nerve, the balance nerve, and the facial nerve. And sometimes we get tumors here, and I'll have a chance to comment on that later also. Well, let's talk a little bit about the hearing first. We'll get on into the balance mechanism and the facial nerve and other things a little later. Now, I suspect that most of you have had your hearing tested sometime in school or in a doctor's office. But for those of you who haven't, let's take just a quick look at what is involved in testing the hearing. This is a typical setup in an otologist office. You'll notice you have an audiometer. This is what creates the sound. The audiologist here, and you can just barely see the person sitting in the next room, a sound-treated room with earphones on, signaling that he hears the tone. Now, there are two things involved in this type of test. One of them is a tone we call a pure tone, and the other one has to do with the hearing for speech. And we'll comment a little bit more later about this matter of hearing for speech. Now, this is a small audiometer. You may see one like this, in the pediatrician's office or maybe at work or something like that. It's a simplified mechanism, similar to the last one, but doesn't come up with quite such sophisticated information. Good deal cheaper, however. For those of you who have seen an otologist about a hearing problem, then you're familiar with what's going on here with a tuning fork, comparing how loud the tuning fork sounds on the bone behind the ear with how loud you hear it, I should say, when held by the ear. Because this is a fundamental, basic, old-fashioned tool that otologists still use to differentiate between the two major types of hearing impairment. Now, the otologist, by placing the tuning fork, hitting it first, and then placing the tuning fork behind the ear and by the ear, can come to the conclusion as to whether the type of hearing impairment the individual has is a conductive type or a sensory neural or nerve type. And there's very great importance in making this differentiation, because the conductive type is usually correctable surgically. The sensory neural or nerve type is not. Let's take a look at the slides to demonstrate this more clearly. Okay, you notice here, this is our same slide I showed you before. You'll notice here that the area of the ear canal and the middle ear are shaded in. Just to point out that any type of problem in the ear canal or the middle ear that causes a hearing loss will cause a conductive impairment. That is, something that prevents the sound from getting in the way it should into the nerve. This could be a hole in the eardrum, something wrong with the little ear bones, fluid in the ear, and we'll talk a little bit more about that later. But this is the type that can usually be corrected. Now, when the problem with the hearing is in the inner ear area, specifically in this area we call the cochlea, or in the nerve itself, then we have what's called a sensory neural or nerve type of impairment. There's nothing wrong with the transmission system. The problem is entirely in the nerve. This is the type of hearing impairment that unfortunately cannot be corrected. Now, I think it's important to say right at this point that it's rare for any type of hearing impairment to lead to true deafness. That is, to where the person cannot hear at all. Many of these hearing impairments, whether they be conductive or sensory neural, can lead to a severe degree of hearing loss. But the individuals can always hear, either through surgery or with a properly fitted aid. But I want to talk a little bit about this matter of sensory neural hearing impairment, the nerve type, because at least at the present time, it's unusual, very unusual, to be able to do anything substantial to correct it. Generally speaking, sensory neural impairments fall into the category of ones that are preventable. There are a few that are treatable, and then there are all the others, the majority of them, for which we can really do very little. The preventable types, well, you've seen at the airport, the people that work around jets, they wear these big ear muffs on both ears. That's to protect their ears from noise. So noise damage to the ear is preventable by wearing ear defenders when exposed to excessive noise. Another type that's preventable is a type that's caused by certain antibiotics, not frequently used, but used for very serious infections. Antibiotics that are effective only by injection. And when the doctor does that, he has to be very careful and monitor the exact blood levels to make sure that it doesn't cause hearing impairment. There are a few of these that are treatable. Some circulation problems of the inner ear are treatable. Syphilis, a few other infections, and there are a few tumors that can cause hearing loss that when you treat the tumor, the hearing loss disappears. But by and large, most of these hearing losses, the sensory neural type, are not treatable. And the commonest cause is the type of hearing loss that comes with age. We call this presbycusis. You may have heard the term presbyopia referred to eyes, where the eyes show aging. We call this presbycusis. There are other causes. Individual fractures his skull or has a hereditary type of hearing loss, runs in the family, or the mother who gets measles during the first 3 months of pregnancy, or person after they're born gets mumps, may affect the inner ear. Fortunately, these aren't too common. But the common one is the one that comes on with aging. And I want to spend a little time talking to you about this because it is extremely important to know how this affects the individual so that you know how to talk to him. There are two problems with this sensory neural hearing impairment. One of them is that the sound isn't loud enough, and that can be compensated for quite successfully with a properly fitted aid, usually with an aid in both ears. But the other problem is the matter of what we call poor discrimination. The individual cannot hear words clearly. He has poor discrimination. He's not able to understand them. He always has to ask to have words repeated. And let me tell you why this is, because understanding it is going to help you a great deal in communicating with people who have a hearing impairment, regardless of what the cause of that hearing impairment is. Let me tell you what this discrimination problem is. People with this sort of hearing loss, they can hear the vowel sounds in speech quite well. A, E, I, O, U. They're loud, they're clear, they're low-pitched. No great problem. But the consonants, k, f, s, t, p, ch, f, s, all of these sounds are very high-pitched and soft. And the person with a nerve or sensory neural hearing impairment can't hear these. Now, you've seen already that these sounds are lip and mouth sounds. Fortunately, by the use of their eyes, they can use their eyes, in other words, to help their ears understand what they hear. But obviously, that's of no benefit at all if you're talking from another room or you're talking with a cigarette in your mouth or while you're walking away. Individuals have a great deal of difficulty then understanding. They have to rely on speech reading. They have to stop, look, and listen. They have to listen more carefully, and they have to use their eyes to help their ears understand. Now, you can do a great deal to help these people. The big problem is the person with a hearing loss understands it. I understand it. Now you understand this. But the vast majority of people that they'll come in contact with do not understand that problem. And as a result, it creates a constant difficulty for the person with this sort of hearing impairment. There are a few tips on how you can talk to these people so that they'll understand you better. Let's go back to the slides. Here are a few tips on talking to the hard of hearing patient. You can see them. I don't need to read them for you. Very, very important. This little cartoon demonstrates the fact that this hard of hearing person has to be able to see the person that's talking. And I might mention, don't ever stand this close to the person with a hearing loss. The ideal distance to stand to talk to someone who has a real hearing loss is between 4 to 6 feet. But you want to make sure they can see you, and the light is on your face, the speaker's face. This is to demonstrate, look, this man is talking to a person who's hard of hearing. You can't see his mouth, and he's eating popcorn. Makes it very, very difficult to understand what that individual is saying. This little slide to remind you that are in the medical field that when a person is ill, they're going to have even more trouble with their understanding. If they had some to begin with, they're going to have more trouble when they're ill or in bed or in a room that isn't well lighted. This points up two problems. Here's the hard of hearing person. This person is talking. He's got a pipe in his mouth, so it makes lip reading very difficult, and he's got a lot of background noise going on, and that background noise likewise interferes with the patient's ability to understand what's being said. Let me comment further on this matter of background noise. Many patients, many people who have a hearing impairment of the sensory neural type will tell you, "Doctor, I get along just fine," usually. But put them in theaters, restaurants, churches, auditoriums, noisy restaurants, social gathering, cocktail party, they're dead. They can't understand a word that's being said. They already have a discrimination problem, difficulty understanding, and then you add to that background noise, poor acoustics, and 5 people talking at once. It's a real problem, and the person that has this difficulty is best off to be in a quiet portion of the room, or certainly in a position where he's not surrounded by people, where people can be talking from all sides and in back of him. Now, there's a commonly held belief, in fact, 40 years, 30 years ago even, it was taught in medical school and in training of ear, nose, and throat people that there was very little you could do with a hearing aid to help the person with a nerve impairment. And a lot of that feeling has lasted on. You've heard people say, oh, well, hearing aid, I bought it and it's been in the drawer ever since. Well, there have been a lot of advances in hearing aids, and there's a great deal that can be done to help the patient who has a sensory neural or nerve loss. The key, and it's just been in the last 10 years that we've really appreciated this, is that they usually have to wear an aid on both ears. You put an aid on one ear and then put them in a noisy place, they're just as well off not wearing the aid at all. It's very difficult for them. But almost all of them can be helped. And I thought we might just spend a few minutes looking at some hearing aids, both old and new. Well, you can see this is a very old-fashioned hearing aid, the individual with a hearing loss sitting down here and this person talking in a big echo chamber. I suspect it was very effective in its time. You see the old-fashioned ear trumpet. That's a real instrument. That wasn't designed as a joke. That's the type of hearing aid some people had to use 100 years ago. Have you ever wondered why men always used to wear beards, particularly as they got older? Used to hide their hearing aid. I'll show you what that looks like on the next slide. This is what this individual was wearing. It was actually worn under the beard and had little earpieces that went up to fit in the ear so he could wear his hearing aid. Very old-fashioned. Now, it was very inappropriate for women to wear beards, but they could wear their hair stacked way up on top of their head, and that woman might wear a comb like this with a shell that would collect the sound and help to reflect it into tubes, which would lead into both ears and be quite hidden from view by everyone. Some of you may remember old-fashioned hearing aids that had these huge battery packs. I can remember my grandfather having this in his vest pocket and this strapped to his waist, because it required such a tremendous amount of power 40, 50 years ago. Now, this is the type of hearing aid that we will normally prescribe. This is what's called a post-auricular aid. This fits behind the ear. I think you've all seen people wearing this type of aid, or they may wear it in glasses. The latest wrinkle on the use of an aid is the so-called all-in-the-ear aid. Now, this has been very attractive to many people. They say, aha, nothing to fit behind the ear. The fact of the matter is, these are more conspicuous from a cosmetic standpoint than the ones, the so-called post-auricular ones. Let me say about the all-in-the-ear hearing aid. They're very attractive, they're a big sales gimmick, but the fact of the matter is that there are many problems involved with them. In our own office at the Otologic Medical Group in Los Angeles, where we put patients through a careful hearing aid evaluation, and I want to comment, that's important. It's not a matter of going down and buying an aid from a dealer. You've actually got to find out what will work best with that individual and often fit them in both ears. But what I wanted to say was that only, oh goodness, it's less than 20% of the aids that we prescribe are the all-in-the-ear type. The post-auricular aids, generally speaking, are more satisfactory. Now, up to this point, I've talked to you about two types of hearing impairment. The sensory neural type, we've just finished talking about it. This, due to many different things, cannot be corrected surgically. They have a discrimination problem. They can usually be helped with a satisfactory aid. Now what I'd like to do is to get into the other type. This is the conductive type. This is the type that can usually be corrected. Well, here's our diagram again. Remember I told you sound came in, vibrated the eardrum, and went through the little ear bones. Well, a conductive hearing loss is one that interferes with this transformer mechanism. Something is preventing the sound from getting into the nerve. Now, let's take a look at what some of these are. I've already talked about wax, and if you push wax down so that it completely blocks the eardrum, it can cause a hearing loss. That's not too common. Let me talk about one of the most common ones, and it's a problem that's related to the eustachian tube, which leads here from the back of the nose into this area we call the middle ear. Between the eardrum and the inner ear, this is an area that is normally filled by air, and the air pressure on both sides of the eardrum must be the same for maximum hearing. And that air gets in through this tube, which is about 1.5 inches long, leading from the back of the nose into the ear. It's called the Eustachian tube. Now, as you look at this, you'd say, well, that tube is open. Well, it isn't. That tube is normally closed. It opens up every minute or two to allow air to get into the middle ear. Now, when you have a cold or an allergy attack or sinus trouble, that tube will get blocked up. And when that happens, a number of things transpire. You develop a negative pressure, and then you get fluid in the ear, and if that fluid becomes infected, this whole area of the middle ear fills up with pus, and you have what is commonly called an abscessed ear or a rising on the eardrum. It's an acute middle ear infection. But more often than not, we're left with fluid here in the middle ear area. Let's just take a look at this from a different viewpoint. Here you have the palate and the muscles attached to the palate and this eustachian tube, which leads from the back of the nose into the area of the middle ear. And if you look up here, you'll notice that in the child, that tube is shorter and straight, whereas in the adult, it's longer and curved. This explains, in all likelihood, why children have so much more trouble with fluid in the ear, because this channel can get blocked more easily. You wouldn't believe it from what it looks like here, but it can get blocked more easily. Now, this is a diagrammatic representation of fluid behind the middle ear, serum, and it's due to the fact that the eustachian tube is blocked. Now, when a person develops fluid with a cold or an allergy attack, in most cases when the cold goes away, the tube opens up and the fluid drains out. But in some individuals, particularly in children, this whole area will fill up with fluid. The tube does not again function for perhaps months and months. The child is left with a hearing impairment, and what do? We put in what's called a ventilation tube. This is the eardrum. It's the first picture you've actually seen of the eardrum. It measures about 1/3 of an inch across, and this little tube is only 1/10 of an inch across, but it allows air to get in and out from the outside while the eustachian tube is not functioning. Now, for many, many years, because of the small structure of the eardrum and the ear bones, as you can see on this slide, notice here that you've got the 3 ear bones, the malleus or hammer, the incus or anvil, and the stapes, compared to a dime and a matchstick, extremely small. And because of this, for many years, there was not very much we could do about these problems to restore the hearing in people who had diseases of these areas. But then came along in the early 50s what we call the operating microscope, as you can see here. And we use this for all of our ear surgery. If you look carefully, you can see a little viewing tube on it. And here on the next slide is a picture of me in my earlier days, and you'll notice that I'm sitting down there. Next to me is a student who's looking through a viewing tube to actually watch how the operation is done. And here you have actually a little television camera hooked onto the microscope. And in a short while, I'm going to show you a videotape of an ear operation. Now, let's get into some of the things that we do to correct these various hearing problems. One of the most interesting conditions is a problem called otosclerosis. It has nothing to do with arteriosclerosis, nothing to do with aging. It's a common cause of hearing loss in adults, starts sometime between the age of 15 and 50, with a gradually progressive hearing loss, can get moderately severe. Fortunately, it's almost totally correctable. Let's go back to the slides and see how this works. Well, here's our picture of the ear again, although something has been added. You see this little clump of bone here? This is otosclerosis. It's a hereditary disease of the bone of the inner ear, and when it involves the 3rd ear bone, the stapes or stirrup bone, it causes a hearing loss. And as I say, this is a common cause in adults, and it's correctable. Here you have the stapes bone right here, the stirrup, and here is this growth of bone, the otosclerosis. The only problem it causes is hearing loss. It grows around the stapes bone, or at times it grows in here to the coiled portion of the inner ear that we call the cochlea. Now, you're going to see an operation in just a few minutes as to how this problem's corrected. Here's the stapes bone hardened in place by otosclerosis. you'll see me go into the ear and take the stapes out and replace it with a little wire. Let's take a look at the tape, and I might say that this is an edited tape. The operation took me about 30 minutes. I've edited it down to 10 minutes. This is a right ear, and I've already injected a local anesthetic. Now, the first thing I'll do is to make an incision above the ear, an incision about 1 inch long, and this is to remove the covering of the muscle, what we call fascia. This is a very thin but tough covering, and in this case, a covering of the chewing muscle, the temporalis fascia. And here you see me going through some fat above the ear, and as soon as we get the little bit of bleeding stopped, here we have the temporalis fascia. Now I'm removing a piece that measures about 1/3 of an inch in all dimensions, and I'll take this out, separate it from the underlying muscle. That the material under there is the muscle. We'll later sew that up. But let's take a look at the fascia. Now what I'll do is to put it out on what we call a fascia press. This is to smooth it out and to make it easy to handle. Now to give you an idea again as to the dimensions, that metal plate that I have the fascia on measures about 1 by 1.5 centimeters. Now that means roughly 1/3 of an inch by 1/2 an inch. Spread it out, trim off any little excess material, and then we'll put that aside to use later. Now, the reason for this is that when I later take out the stapes, you'll see that there's some fluid in the inner ear, and this is essentially the same as spinal fluid. And we've got to do something to make sure that that is firmly plugged, you might say, or would make sure that it is firmly sealed so that we don't have any leak of fluid from the inner ear at the conclusion of the operation, because were we to have that, then the patient might have trouble with persistent dizziness. Now I'm putting in just a few sutures here. You're not going to see them all, but they're put in underneath the skin, so there are no sutures or stitches actually to take out. And this is a material we call Dexon. It happens to be an absorbable material similar to what many of you have heard of, catgut, but this is a little bit better, we think. So we'll sew this up, and then we'll be ready to start in the ear canal, which I have already injected to give a local anesthesia. Now my patient has had a sleeping pill or two about an hour ago, an hour and a half ago, and a little bit of morphine to make sure that he's drowsy, he's not asleep, he's able to hear what's going on and to feel that I am working. It isn't causing him any discomfort. Now we're ready to look in the ear, and we're looking down at the eardrum, which doesn't really show too well to you right at this point. You'll see a little skin that I'm taking out of the ear canal just to make it clean so that I can start to make my incisions. Now what we do here is to make an incision in the skin of the ear canal after I put in my final injection. Make an incision in the skin of the ear canal, which will allow us to lift up the skin, and then when we get to the eardrum, lift it up. So here I go, making my first incision through the skin of the ear canal. Now I'm making this at the lower part of the ear canal, and I'll make another incision. Now this incision then allows me to actually lift up that skin, and then as I do, I will eventually get down to the eardrum. Here we are lifting up the incision, lifting up the skin, that is. There's not much bleeding that goes on with this operation. Two reasons. One of them is the injection had a little bit of adrenaline in it, and the other one is that the blood vessels in this area are very, very small. Now I'm lifting up the skin of the ear canal right down to the level of the eardrum. Now once I get to the level of the eardrum, then I identify a little white area which you may be able to see here in just a moment, which is the edge of the eardrum. Here we are under a rather high power, and you'll see me little area where I slip my instrument under, and that's the edge of the eardrum. Now, as we go through there, we get into the area we call the middle ear, the area that's normally filled with air that's just behind the eardrum. Now I'll go ahead and finish lifting up the eardrum and pushing it forward. It's like opening a book. I've just sort of turned the cover forward, so to speak, so I can see what's inside. These instruments are extremely small because we're working in a very, very minute area. The whole eardrum measures no more than about 1/3 of an inch. Now as we look in here, we're looking down into the area of the middle ear, actually the area of the stapes. That's the facial nerve I'm touching there. And we're looking down just below that into what we call the oval window. That's the stapes that I'm touching. Now the first thing I'll do is to separate the connection between the second ear bone, the incus, and the stapes. The next step is to measure the distance for the size wire, and you'll notice this instrument which has a little gadget on it there that's shiny. Now that is to measure the distance between the second ear bone and the inner ear so that we know what size prosthesis. The next step here is taking us very small scissors and cutting a tendon, the stapedius tendon. Then take an instrument and crack the stapes loose. Break it loose. There it goes. Move it out of the way and then lift it out. Now that stapes bone measures about 1/5 of an inch. 1/5 of an inch in various dimensions. It's very small. Now I'm going to take a small hook and remove the rest of the stapes. What I'm doing here is removing the portion that was actually hardened in place. We'll take it out. Now that area it's coming out of measures about 1.5 by 3 millimeters. That's very, very small. 3 millimeters equals just a little bit more than 1/10 of an inch. We'll take out the rest of the stapes. Now you'll notice as we take it out there's some shiny fluid down there. You can see a little what we call light reflex from it. Now that fluid that we call perilymph, it's like a watery fluid that bathes the inner ear, but it's actually the same as spinal fluid, and that's the fluid that we're going to have to keep from draining out, from leaking out, so to speak, and that's the area where I will put that fascia that I took out earlier in the operation. Here I go getting the remainder of what we call the foot plate, the remainder of the stapes that was hardened in place. Now right at the present time I'm working under 6-power magnification. Of course it's lots bigger than that to you because you're looking at it on a television screen. Now we have things ready to go. So the first step is, the next step anyway, is to put in that fascia. Now there it is. It's been dried out, so it's easy to handle. This is a piece of temporalis fascia measuring 1/5 of an inch, 1/5 of an inch in all directions. And I slide it in over the area of the oval window. That's the area where the stapes was before I took it out. Move it into place, get it in proper position. You may have noticed a little strand that I'm touching there periodically that sort of goes diagonally across the field. That's what we call the chorda tympani. It has to do with the taste sensation, and it's because of this that patients frequently get a temporary taste disturbance following surgery. Now it looks like we have the fascia in just about the right position. So at this point we're ready to put in the prosthesis. Now this is a small piece of tantalum wire with a little gelatin on the end of it. And the total length of that prosthesis is 4 3/4 millimeters. Again, just about 1/5 of an inch. Now I slip it into place, and the next step after doing that and getting it in the proper place is to put it and to push it over the incus, the second ear bone. And I'll take a little instrument to actually push it into the proper place. Once I have it in the proper place, I'll take a small pliers. Actually, we call it a crimper, but it's just like a very, very small pliers, and tighten the wire onto the second ear bone, the incus. And at this point, the patient suddenly says, "Doctor, I can hear," because I've now connected this up. Now at this point, essentially, the operation's over with. Next thing I do here is to put back the skin and the eardrum, and then put a bandage on the patient's head, and the patient's ready to go back to the room. Well, you've just seen a stapes operation. You know, this is most dramatic. These people usually hear right at the time of surgery, and fortunately it's one of the most satisfactory operations we perform, because well over 90% of them are very, very successful. Unfortunately, it's not the most common operation for an otologist, such as I am, to perform, because the problem, not only in the United States but all over the world, is what we call chronic otitis media. These are people that have holes in their eardrums and draining ears and so forth, and we should say a bit about that. Now here's our diagram, which you have become quite familiar with, and what I want to do is to show you some pictures of an eardrum membrane, and we are going to be looking down through the ear canal at the eardrum, which measures about 1/3 of an inch across. Let's take a look at one. Now this is what an eardrum actually looks like. You'll notice, this is the first ear bone, the malleus. Actually, part of the malleus is out of view, and you can see through. The eardrum is so thin you can see through it. It's translucent. Here is the second ear bone, and you just barely get a shadow of the stapes here. Now here you have an eardrum that has a hole in it. Here is the first ear bone, the malleus. Ignore this. This is just a reflection off the ear canal. And here you have a hole in the eardrum we call chronic otitis media. Let's take a look at this as a diagram. Here we have a large hole in the eardrum. You see the first ear bone, part of it is hidden behind the bone here, part of the second ear bone here, and there's the stapes bone. This is what we call a central perforation. We'll comment a little bit more on that in a moment. Now here we have, you remember that last one, you had a hole in this part of the eardrum. We called it a central perforation. This is one we call an attic perforation, a hole in the upper part of the eardrum, and this is a real problem because skin grows through that hole. And when skin grows through that hole, it forms a skin-lined cyst in the mastoid bone. And it looks like this in a diagrammatic form. Here we have the ear canal and the eardrum. There was a hole in the upper part of the eardrum, and through that has grown skin and formed this skin-lined cyst in the mastoid that we call a cholesteatoma. This eats away bone of the mastoid, eats away the little ear bones, and at times breaks into a balance canal and causes severe dizziness. Now, any of these conditions related to holes in eardrum frequently eat away ear bones. And here we have a diagram showing the eardrum, and ghosted in are the first two ear bones. They're missing, and all we have is an eardrum and the third ear bone. Now, to replace this, to connect the eardrum to the inner ear, or the stapes bone, to transmit the sound, we frequently use a plastic prosthesis, such as shown here or over here. Now, operations to correct problems with holes in the eardrums and replacing of ear bones and removing of this cyst, the cholesteatoma, from the mastoid are called tympanoplasties or tympanoplasties at times. As I said, this is probably the commonest major operation performed by an otologist. And I should comment, I passed over it very lightly. Central perforations, that was the big hole in the middle of the eardrum that you saw early on. These ears drain when you get water in them or when you catch a cold, but normally aren't associated with an unusual amount of hearing impairment. Now, the cholesteatoma, the cyst in the mastoid, however, is often associated with a very great amount of drainage, and oftentimes the drainage has odor because of the dead bone that's being eaten away. These are ears which, of course, must be operated on to prevent complications. And you know, I have a little note to myself here. I've forgotten to say anything about tinnitus, this noise in the ear, and I mentioned that early on. Almost all of the hearing impairments that we've talked about are frequently associated with tinnitus or noise in the ear, maybe ringing, buzzing, and so forth. Now, I might say that there are an awful lot of people that have noise in the ear that don't have hearing loss, that is, and there's not any necessary relationship between head noise and hearing loss, but they usually go together. Now, if the hearing loss is the type that can be corrected, such as we've just talked about with holes in eardrums or otosclerosis and replacing ear bones, frequently the head noise is less following surgery, and it may go away completely. But often, once it's been established, it stays. And head noise is due to the fact that something, bone growth, infection, or something else, is causing an irritation of the delicate little nerve endings, one of these 24,000 nerve endings in the inner ear. And when that happens, that nerve sends out an electrical impulse to the brain. And you see, anytime an electrical impulse comes in on the hearing nerve, the brain says, must be sound. The person hears a noise in the ear. Now, for years, we could do very little about that. We all know that putting a hearing aid on, if there's a hearing impairment with it, putting a hearing aid on often helps a great deal because it brings in all the background noise. And if there are any of you in the audience who have head noise, you know that if you're in a noisy place or something like that, that you don't hear your head noise. Okay. Same thing. You put a hearing aid on, brings in the outside sound, individual doesn't hear the head noise. Now, unfortunately, this doesn't solve the problem for everybody. And recently we've learned that what's called biofeedback treatment. This is a matter of learning to control your inner functions. You can control your blood pressure, the temperature of your hand, your pulse rate. Normally things that you don't think of being able to control, you can learn to do it. Similarly, you can control the head noise. Make the brain push it back into the subconscious, so to speak. Now, the most recent development in regard to tinnitus or head noise is what's called a tinnitus masker. And interestingly enough, an individual can accept outside sound better than they can their own. And when you get someone who cannot tolerate this head noise, most people do, understand that head noise eventually usually disappears or gives the person little trouble. But if it is presenting a problem, these individuals can wear a little device very similar to that post-auricular aid that I showed you in a slide earlier that puts out a noise here that keeps the individual from hearing his inner head noise. Interestingly enough, it's very, very successful. You can tolerate an outside noise better than you can an inner head noise. Now, there are a number of other ear problems that we haven't talked about, and perhaps we should go back to the diagram and we'll just touch on them lightly. All right, we talked about sound coming in, vibrating the eardrum, going through the little ear bones to the inner ear, and what happens if something happens to the eardrum or ear bones, and what happens if something happens to the hearing nerve. But in the inner ear, we also have balance canals, 1, 2, 3, and a balance nerve. We also have the facial nerve. This is the nerve that goes all the way through the mastoid, comes out down here and supplies muscles of the face. And we have the internal auditory canal with the hearing, balance, and facial nerve. Now, problems in any of these areas can also cause difficulty. Now, when we take a close-up view, here's the middle ear and the eardrum and so forth. In the inner ear, these little red marks are what we call the macula and the crista and so forth of the balance mechanism. And they're very sensitive to any motion and also very sensitive to any change in circulation. Any problem along that line can cause a balance disturbance. And you know, I think it's sometimes you don't realize how small these areas are. Here's an ordinary dime. Here is the coiled portion of the inner ear or the cochlea, and here are your 3 balance canals. Very, very small. So the balance mechanism is very, very minute, and it's very, very sensitive to any minor disturbance. Now, for the most part, you and I aren't aware of that because the body adjusts very easily. The brain does. It's used to constantly getting impulses. There are a number of diseases which may produce dizziness. The one that most of you have heard of, I suspect, or if you've heard of any, is what's called Meniere's disease, where they get spells of dizziness and hearing loss and noise in the ear. It's really not very common. Most cases of dizziness aren't due to that. One of the commonest single problems with dizziness is dizziness related to the aging process. You see the individual who gets dizzy when he lies down or rolls over in bed. Dizziness lasts 10 or 15 seconds, or when he first gets up in the morning, lasts for maybe 15 minutes, or any time he's out walking, perfectly fine sitting still, but when he goes out walking, he just feels insecure. He's not dizzy, he doesn't fall over, but he's a bit unsteady. These are problems that come on with aging. Fortunately, most of us don't get them. They're not progressive, they are harmless. And it's a complicated mechanism in the aging process because the balance mechanism really has to do not just with the ears. You have the ears, the three balance canals in the ears, you have the eyes, and you have the spine and the muscles and joints. And anything going wrong in any one of these three areas can cause a balance disturbance, and when you get them all involved, as frequently happens in an older individual, for instance, they get a little aging change in their ear, no problem. Then they have their cataracts operated on and they're having trouble. Or they've had a little bit of problem here and they got a little bit of hip trouble, a little bit of arthritis. They're getting along all right, and then they have to go to bifocals, and all of a sudden they start to have a balance problem. So it's a very complicated thing. Fortunately, as I say, these problems in the aging process are not progressive. For completeness' sake, I want to say a word about the facial nerve. Here's the ear canal. We're looking down on top of it, ear canal, eardrum. Facial nerve comes in like this, winds all the way through the ear, and in the process of doing so, gives off a branch that causes tearing of the eye, another one of taste of the tongue, and another branch that supplies all the muscles of the face. I put this in merely to indicate why, if you've got a weakness of the face or a paralysis of the face, you frequently end up in the hands of the otologist to diagnose the problem and to decide what needs to be done. There's a great deal of research going on. I've already clarified for you that we can't cure, we can't even prevent a lot of our problems with sensory neural hearing impairment. There's a lot of research going on here at the Ear Research Institute and at many places in the world. And one of the first big dividends that's come from that here at the Ear Research Institute is what's called the cochlear implant. And I'd like to say a few words about that so that you understand what's going on. This cartoon appeared in the Los Angeles Times about 2 or 3 years ago, and with a caption it says, "We implant this behind your left ear and you won't even know it's there." Well, when it starts hitting the newspaper, that means that you're going to get asked questions about it, and let me show you a little bit about what's going on. Okay, here's another diagram of the ear, and we're interested in this coiled portion of the inner ear we call the cochlea, and if we look at this highly magnified, it's got 3 chambers in it, and it's got this little area where these delicate little nerve endings are. Let's look at those closely. This is what we call a cross-section of the cochlea with its 3 chambers and these little hair cells, and these are what institute the electrical impulse that lets us hear. Now, some people, when they develop a nerve hearing impairment, develop it due to the fact that these little hair cells degenerate and are no longer creating an electrical impulse. We learned that we could put a wire into this coiled area, into the cochlea, and introduce an electrical impulse that the ear itself was not producing. This wire is then connected to a transducer implanted in the bone under the skin, and then electromagnetically a current is induced in this from the outside, which then sends an electrical current into the cochlea to stimulate the nerve endings. Here's the apparatus. It shows like it's on the outside of the skin. Actually, it's underneath the skin in this area. These wires go through the mastoid and then go into the coiled area of the inner ear. The cochlear implant's a fabulous development, but it's important for you to understand that it does not restore normal hearing. It is not a hearing aid. What it does is supply an electrical current so that the individual can hear some sound. They hear environmental sound. They hear the vowel sounds in speech. They hear the door closing, the dog barking, the fire engine going by, and it helps them a great deal in their speech reading. We think it has a great future for those who are truly, totally deaf and cannot use a hearing aid. Well, we've just about drawn to the end of our little session here, and I want to just review with you briefly. We've talked about two types of hearing impairment. The nerve type impairment we call sensory neural, big problem, understanding speech. Very important to get the person's attention so that he can stop, look and listen, and can see you, because he relies on his eyes to watch your face and lips to help his ears understand what they hear. This is the type we cannot correct surgically. We then talked about the conductive type of hearing impairments, maybe due to fluid in the ear, hole in the eardrum, missing ear bones, ear bone hardened in place. These are things which can be corrected surgically with a high degree of success in most cases. And I started off by talking about wax. You've got to take care of your ear. Don't put anything in your ear smaller than your elbow, protected from noise. And if you have a hearing loss or tinnitus or dizziness, see your otologist to find out what's going on and what can be done about it. Thank you very much.